right, welcome back. We are about to start session 10. Let me introduce the first speaker, Dr. Bridget Wills. She actually needs no introduction, from University of Oxford. Bridget is going to talk about the many different phases of severe dengue.
Good afternoon, everyone. I'm delighted to be here, listening to so much interesting science and debate about important topics related to dengue. I was going to thank the organisers for my invitation, but then I read the session objective: to collaboratively define a clear and actionable metric for assessing dengue severity that can be universally applied in pursuit of a dengue endgame. Well, thank you, Adam. I'm sure we'll manage that by tea time. It's not something that's been, debated for 20 years. Anyway, moving forward, I have to, yes. So I'm sure for everybody in this audience, they're very familiar with this cartoon from WHO about the clinical evolution of dengue, and I'm sure also everyone is very familiar with the wide spectrum of clinical manifestations from asymptomatic infection through to paucisymptomatic disease with mild fever and a bit of vomiting for a couple of days, through to severe disease, potentially with dengue shock syndrome, major bleeding, severe organ dysfunction, and potentially death. So this very wide spectrum of disease, how are we to come to I can't remember all the words, but anyway, this easily applicable system of defining severe dengue? I think one of the things we have to do is think, what are the scenarios in which we wish to use such a definition? Because depending on those scenarios, the actual tools that we would like to have may differ. And there are many scenarios, but a few. One is, I'm a clinician, it always comes first, the patient. Effective clinical management of individual cases. Now, for that to be effective, we need to have a real-time assessment here and now. The patient is in front of you. Am I worried about this patient? What should I do? Is this patient severe, or is this patient likely to become severe tomorrow? So we want a system that we can use to assess them here and now, and if possible, we'd like a system that could be applicable to predict whether they're likely to become severe in the next few days. Other scenarios, one is epidemiology and surveillance. We would like to be able to compare between different locations and over time in different scenarios what the relative rate of clinical presentations is. And in that circumstance, we don't need to be able to do it here and now. We have the luxury of being able to look retrospectively. So it's possible to collect data, look back, have very clear definitions and say, this case was severe, this case was not, or to have algorithms that do it. It's very unlikely to be individuals doing it. And then finally, we have, well, it's not finally, a third scenario, there are many others, is for research along the lines of what we've been discussing for the last couple of days. So in order to understand pathogenesis, to assess vaccines, to do intervention trials of new antivirals or Wolbachia, we need to have some metric on which we can assess the outcomes of those interventions. Similarly, it's possible that we might want to have some metric to decide on which patients to enroll in trials in order to reduce trials are getting increasingly big these days, but if we want to try and have the most economically viable trials, we want the minimum number of patients that will answer the question. So if you've got a very heterogeneous disease, trying to identify those that are most likely to become severe are maybe the ones that you want to enroll in your trial. So again, for research, we have the possibility, not for the enrollment criterion, but for the outcome assessment of using retrospective analysis. So we can decide in advance a systematic approach to what we are going for this trial to decide is severe disease, and then we can collect data on all the patients and subsequently put them into the different categories. So the requirements for a system vary according to the scenario in which you wish to use it. And I suppose what I'm trying to highlight at this point, which is what many people have been highlighting so much in the last few days, is that the whole situation is very heterogeneous. We have a wide spectrum of clinical presentations. We have anyone from the newborn to the age of 80, people with underlying diseases, people with different genetic backgrounds, doctors with different experience who may be facing different clinical scenarios in their environment. There's so many different variables that go into it that actually defining a single algorithm that would be applicable to all of those is, I think, a tall order. So, how common is severe disease? Depends again on how you define it and your denominator population. In many of the vaccine trials that have been published, the actual number of severe disease according to criteria like occurrence of dengue shock syndrome, which I think is recognized by everybody as a manifestation of severe disease, they're tiny, tiny, tiny numbers. Of course, if you expand the definition to include dengue hemorrhagic fever, or what we might now call intermediate or moderate dengue, and if you change your denominator from intensive care populations through to hospitalized cases or outpatient cases, then obviously the frequency of the outcome varies. I'm not going to talk about this particular study, but we have recently, actually it's not recently anymore, but we have in the past done a big study enrolling 7,000 patients around the world, characterized very carefully using the same CRF in many different countries and with very careful laboratory data collection, very formal outcome definitions, etc., etc. And out of 2,230 patients who had laboratory-confirmed dengue, we had 36 children, 36 cases. They were children and adults who had what we termed severe disease, by which we meant dengue shock syndrome, severe bleeding, or severe organ dysfunction. So the current WHO 2009 definition. And we had about 14% who had what might be called intermediate disease. So most people have uncomplicated disease. Well, actually, most people have asymptomatic disease. Amongst the symptomatics, they have uncomplicated. Then we have a reasonable number of moderately severe illnesses and a very small number of severe disease if we are strict about the definition. So there we are. I've already said that. Now, Alan, yesterday I was a bit sad to see that you had the elephant, because I was planning to have the elephant. So here is the elephant again. I think the point about it is showing, it's a very old, I can't even think of the word, but anyway, it's trying to encourage the view that we should consider lots of different opinions, or the opinions of others as well as of ourselves, on complex situations. And I would argue that it's not just a number of people looking at the elephant that will help us to identify what the actual shape of an elephant is, that maybe we have to look at lots and lots and lots of elephants. Because by looking at the big picture, we get a better idea of what the variability is, the heterogeneity in the population, in the disease population, in the patient population, in the doctor population, etc., etc. So, I think this is a publication that came out a few years ago that very nicely summarizes the number of different factors that go into or can go into the development of severe disease. So we have immunological, virological, human host factors, and clinical management. And altogether, they can contribute to the development of severe disease. And there have been a lot of discussion here and in the past, and indeed here, about what evidence do we have for these factors. Well, one of the things that we have been doing in Vietnam for the last 25 years is looking at a lot of elephants. So we have set up prospective observational studies that look at large numbers of patients. We started with severe cases in the intensive care, and we've amassed more than 2,000 DSS cases that have all been carefully documented in exactly the same way, with exactly the same blood tests at exactly the same time intervals. We then moved to hospitalized children, then to hospitalized adults, then to the community, and then moved on to multi-center studies around the world. So we have huge databases which are very valuable for trying to answer complex questions, particularly where you have this issue of heterogeneity. I'm not going to go into any of the major details, but just to briefly summarize the question of viremia. This is a study that involved 6,500 of those patients, which clearly demonstrates that higher viremia is associated with more severe disease, both in terms of severe dengue, defined here as dengue shock syndrome, or the WHO 2009, but they were nearly all DSS. There were 250-odd severe cases, nearly all of them were DSS, or plasma leakage, which is what in children particularly we worry about, because it's what predisposes them or what leads on to DSS, and hospitalization. So all of those outcomes were clearly associated with each serotype, with primary disease, but much more so with secondary disease. And that was possible to say because we have these very big databases. We've also looked at lots of biomarkers using these big databases. I don't have time to go into the details, but it's clear that there are many different biomarkers that influence the severity or likely progression of dengue. There's huge variability within individuals, or within individuals over time and between individuals. And if you try and look at different groups, for example, children versus adults, you find there are different factors that are more strongly associated with the severe disease outcome. So we're not going to find, or in my opinion, we're not going to find a single biomarker that's going to answer the question. It'll be a complex association of a number of different variables, probably with a clinical algorithm that looks at 10, 20 factors that might influence progression to severe disease. Coming back to the clinical, the host factors, which is what I wanted to focus most on today, from our databases, we are able to look at the things that if you don't have biomarkers or sophisticated laboratories, the thing that most people rely on is hematocrit and platelet. Those are the well-established characteristics or parameters that people judge severity on, as well as, of course, the clinical syndromes. I'm only going to talk about laboratory parameters because they're much easier to represent in terms of data, but the same can be applied to the clinical parameters. So thinking about hematocrit and platelets, this is 10,000 cases with daily full blood counts during the acute illness, and then followed up at various intervals up to about 6 weeks. Every patient had at least one follow-up. And so this is all the sequential data, and I don't know if the pointer works, but anyway, you can see, so blue is non-dengue, so 10,000 patients, 3,000 did not have dengue, because we enrolled them as suspected cases, 7,000 had dengue. You can see that there are very similar patterns, but that the dengue cases had a clear dip in platelets to around about day 5, 6, and then rising to an overshoot and then settling down to the convalescent value. By contrast, we don't see very much difference between the hematocrit and platelets, which, given that most of these did not have severe disease, is not that surprising. Modelling it, and this is just much easier to look at, we can see that the non-dengue cases do have a change, but not very much, in their platelets, a little dip and then an increase. The dengue without shock have a more pronounced change, dip, increase, and the dengue with shock have a much more pronounced. For the hematocrit, we see that it's the dengue with shock, as we expect, that have the major changes in hematocrit. But of course, this is compounded by fluid management. So these children had lots of fluid, and if you see the rebound dip down to about day 10, you can see that there's quite a marked reduction in hematocrit. And if we're thinking of how to define percentage hemoconcentration, then if you take the peak and the dip, it'll show very clearly that there's a lot more than 20% change. And I guess what I'm trying to say is timing is everything. When you want to do comparisons between individual patients, you can't just think about the peak platelets or the nadir platelets and the peak hematocrit. You've got to think about the timing, and there are quite clear age and sex changes. So platelets are higher in younger children, and this is already known from other diseases, not from dengue, but it's clear that there are differences in platelets. And clearly the hematocrit, we all know this, but who has baseline hematocrit data for their population? Very few countries have it. So they tend to use cut-off levels. Cut-offs are fine for research, but for individual patients, it matters what their baseline was. So how do we assess that? Maybe the best thing we have is the population data, but we need to think that it changes both with age and sex. And of course, 80-year-olds, our population goes up to about 35, so our 10,000 cases, there's hardly anyone over 40. So if you're looking at this kind of information for other populations, you really need to be collecting it. How can we assess severity in the elderly if we don't know what their background level is likely to be? So I would urge people who are seeing lots of elderly patients with dengue to start systematically collecting this kind of information. And with the information systems that are now being incorporated into hospital management, it should be feasible to start getting a foothold. It takes 25 years to get to 10,000, but it'll take forever if you don't start. The other group that I just want to, in 2 minutes, very briefly talk about, because we've started 5 years ago, we started looking at pregnancy. So we've only got 200 pregnant women with dengue that we've followed in that sort of very detailed way. But it's a start, and it gives us a lot of information about how to interpret data in the pregnant population versus non-pregnant control women who were age-matched within 5 years and matched for the day of illness, because the evolution pattern, as I described, is crucial. So huge amounts of data, don't worry about most of it. We have controls in red, first trimester is green, second trimester is blue, third trimester is purple, and we can see that at the different times, all of the different parameters change. So sorry, these are individual lines for each individual patient, and then there are median smoothed lines. So it varies, and one of the things is what are the normal values for pregnant women? Just like normal hematocrits and platelets in endemic dengue countries, very few people have data on what the normal values in pregnant women are, but we were fortunate that this study came out earlier this year. So this is 3,000 Israeli women who were followed throughout pregnancy for a whole number of parameters, again, medians and confidence intervals. And if we superimpose our data on this data, we can see that actually the hematocrit changes, it's very difficult to identify because there is normally a drop in hematocrit in pregnancy, and we can see that the dengue-infected women have very little change. We also see some odd things like fibrinogen we would expect to increase. We have very low levels of fibrinogen here, and that is a serious risk for pregnant women, particularly in the final trimester, because, of course, if they've got no fibrinogen, they can't clot at the time of delivery. So don't worry about the detail. It's just that collecting data is really valuable. And if you get big data sets, then you can... Sorry, have I gone over 18 seconds? Characterizing dengue is difficult, but it's not impossible. Severe disease is very rare. I think an intermediate category is useful, and whether we define it as DHF or intermediate dengue or whatever, it doesn't really matter. We just need to have everybody's agreement on for the scenarios in which it's going to be used. For epidemiological purposes, we can look retrospectively, but we need consensus on what data should be collected. For research purposes, it's similar, and that's why a meeting like this would be really valuable, to have people come together. I've heard in the different presentations people refer to X, Y, or Z was associated with a severe outcome, but we don't actually know what the severe outcome was. In some cases, people are talking about a low platelet count. Well, that is very different to the scenario of dengue shock syndrome. So consensus for research should come from meetings like this. For clinical management, I think it's much more difficult. And we need to do a lot more talking and a lot more involvement of actual clinicians on the ground who are practically involved. And I'm 1 minute and 36 seconds over, so I'm going to stop. Systematic data collection. Thank you very much to everybody who's involved. 2 faces of Ho Chi Minh City now. Very different, but both current. Thanks to all of the contributors who were huge numbers. Researchers, patients, collaborators, funders, the whole gamut. But in particular, these 2 people who are both Vietnamese doctors who know an awful lot about dengue, but they're also brilliant biostatisticians, and they drew all the graphs and did all the analysis. So I'd like to thank them in particular. Excuse me, I need a drink. Sorry.
Thank you, Bridget, for the excellent insight.